I'd like to now introduce to you Dr. Michelle Farrar from the Sydney Children's Hospital in Sydney, Australia, and she's going to give us an overview of SMA management and treatments in 2023. I'd like to take this opportunity to thank Michelle for her time. It's really great to have you here tonight. So welcome and thank you.
Good evening, everyone, and especially thank you to Julie. It's an absolute privilege to join you all and support advocacy beyond borders. And apologies in advance, I can't cover the whole treatment and management of SMA in 1 hour. And I think it's a huge task, but hopefully this will set a foundation for future forums. And I'm very happy to sort of take topics on notice and do more with people if that is what works. And certainly I also understand that it's a mixed bag of people coming with lived experience, clinical expertise, and parents and families as well. So it's a delicate balance to pitch it at the right level. So I think if there's terms that are too technical and you don't understand, please raise your hand or put it in the chat box and I can explain it. And also there'll be questions time at the end, so you can post those in the chat and we can discuss those as well. So if we just move to the next slide, I'm really going to talk for those about what is SMA, and also, well, we now need to go back to the other slide. Talk about diagnosis, because when we're talking about treating SMA, it's very important to have the diagnosis correct, and I'll explain why that is. What the treatment options are, and treatment is not just medications and genetic therapies, but it's also multidisciplinary care, and they go hand in hand, and you can't really have one without the other. And also, I think looking on the horizon and the future, getting ready for newborn screening. So first of all, on the slide, what is spinal muscular atrophy? And you'll see from the picture that's illustrated that it is a disorder that involves loss of spinal cells or motor neurons, and that's the really dark purple picture where they live in the front of the spinal cord. And the loss of them causes scarring, which is the dark purple. And it's those spinal nerve cells that connect to muscles. And the pink picture down the bottom is a muscle biopsy. And you can see that normally muscles are like a piece of steak and they're all the same size, but you can see that the size of the muscle fibers are very different. And that's because the motor cells that, motor nerves that connect with muscles that are disappearing and are sick disconnect with the muscle cells, and that causes them to shrink or atrophy, hence the name spinal muscular atrophy. And sometimes there is a compensation where some of the nerve cells that are still remaining can compensate and grow to make the muscle cells around them bigger. And you can see that there's very large muscle cells as well. Now, SMA is very broad in terms of its severity. It can be very severe starting early in life, or it can start in adult life and have a milder course. And really the spectrum is differentiated by the age of onset, and that without treatment also relates to the maximum motor milestones are achieved. And that's the historical classification of SMA. But there's more than one type of SMA. There's also other genes that can cause SMA. And broadly, we describe it by the inheritance pattern. Is it that both genes are not working correctly, or is it that one gene is not working correctly? And that's a different type of SMA than what we'll be talking about. And there's also SMA that mainly affects muscles close to the body, such as the top of the legs and the shoulders, which we call proximal, which is the most common type of SMA. And there's also distal SMA, which affects the hands and feet more. So there's many types of SMA, but the most common is the SMN, survival motor neuron SMA, which is what we're going to focus about tonight. So on the next slide, you'll see the genes that underpin that type of SMA, which is the most common type. And it's caused when both copies of your gene, the one from mum and the one from dad, both aren't functioning correctly. And that is the SMN1 gene. It gets confusing with the ones and twos. So when you are not having a working both copies of SMN1 gene, it means you are not making the really important survival motor neuron protein. And that's what causes SMA. Now, there is a backup gene, and that backup gene only happens in humans and chimpanzees, and it's called the second gene, SMN2 gene. Now, it's very similar to the first, and that's because in evolution, it flipped over and photocopied itself with just a couple of spelling mistakes. Now, the spelling mistakes actually don't change the code for the protein, but it changes how it's all put together. So it's missing a small amount of the important ingredients for the protein. And that means that most of what is made isn't functional and doesn't work, but about 10% is. And that's why people are born with SMA, whereas other animals like mice can't be born with SMA. So this is the backup gene, and it's called SMN2. And so both genes can be targets for treatment, understanding what causes SMA. And the other thing is that the number of the backup genes can vary between people. Some people have 2 backup genes, some people have 3 backup genes, some people have even more, 4, 5, 6, 7, 8. So when we talk about SMA, there's types of SMA which describes age of onset and severity. And then there's 2 genes, and then there's different numbers of the second gene as well. So it does get very confusing. But the numbers of the second gene are important because we know that the more of the second gene you have, if you don't yet have symptoms, it helps us predict what type of SMA you may well develop in the future. So people or babies with less numbers of the backup gene of SMN2 are more likely to develop severe disease. An example is 2 copies of SMN2 is most likely to develop severe SMA type 1. Whereas if you have more copies, you're more likely to have a milder type of SMA. So if we go on to the next slide, this really summarizes it. And so what we see here, I'll skip over this quickly, is that SMA type 1 is the most common. It's about 2/3 of new cases of SMA. And without treatment, these babies have symptom onset very early in life and don't obtain the ability to sit and have a life expectancy of less than 2 years. Type 2 has onset in infancy and children sit but don't walk without treatment. And type 3 have onset usually in childhood and learn to walk, but that may not be maintained without treatment. So it's important when we're thinking about treating SMA in terms of diagnosis on the next slide to make sure we understand what gene is involved, because if we're going to treat SMA, we're really targeting those genes and we're trying to improve the production of the SMN protein. But if your cause of your symptoms and your neuromuscular disease is not due to SMN, those 2 genes, then treating those 2 genes isn't going to help you. It's just going to give you side effects, but no benefit. So therefore, if you move to the next slide, you'll see the diagnostic evaluation. It's really important that before we start any treatments, because they are so specific and so targeted at what the cause is, that we get the diagnosis right. So you do need to have a genetic test that verifies exactly where the changes are in your gene. And this is a publication for clinicians that's been produced in the Lancet that tells you that if it's not straightforward, what you do, because there can be some more important testing to do to actually confirm that. And certainly if it's difficult and you're getting one change but you can't find the other, we'd all be very helpful to work together to help work out what the next best steps forward are to confirm that, because we certainly don't want to be starting treatments if we're not sure what's happening. And if we look on the next slide, this really summarizes the treatment strategies. So on the left is the SMN1 gene, the blue, oh no, it's not, it's on the right. So if we wanted to treat SMA by targeting the SMN1 gene, it's not working and it's not going to work, if that's your cause of SMA. So that's when you would actually transfer a new fully functioning copy of that gene. And that's called gene therapy, gene transfer therapy, or gene addition therapy, gene replacement therapy. They all use different words for it. But the treatment that has been studied and looked at for safety and efficacy by all the regulatory bodies around the world, and that is called onasemnogene abeparvovec. Okay, so if you're missing the SMN1 gene and it's not producing functional protein, one strategy is to transfer a functioning copy of that gene in. But there are other strategies that work as well, and they're all very good. And they actually work on the backup gene, SMN2. So one of them you can see is an antisense oligonucleotide called nusinersen. Now, it is also a small strand of DNA, but it actually is made to bind to the second gene. And it's like a TV remote. It actually is turning up the volume so that that gene is producing more of the fully functional working SMN protein, because you'll remember from the previous slide, you make about 10%. But if we turn up the volume and we actually are using the fast forward on the remote button to stop the glitches in the middle, we can actually make that work and actually make exactly the same product as the Zolgensma or the onasemnogene abeparvovec. This also makes fully functional, fully working SMN protein. So that's pretty neat that we come with our own DNA with a solution for SMA. And then the third strategy is risdiplam. And this is a small molecule. It isn't DNA. It binds to the SMN2 gene, and it also turns up the volume to make more of the fully functional SMN protein. Now, they are the three therapies that have all been tested and have been studied to show what the safety is and what the treatment effects are in a range of different people. And they've all been reviewed by scientists and pharmacists and shown to be effective treatments for SMA. But there are others in the pipeline, and they're sort of looking at other ways to improve SMA, not just at the protein, SMN protein level. There's exercise, there's targets in the muscle itself, and that you might have heard of is the Scholar Rock program. And then there's pyridostigmine as well. So if we just go to the next slide, you'll see that there's so many different treatment options, and I think that is a good thing for SMA, because one treatment may not be the best treatment for you. And so being able to choose which is the best treatment for you is really important. And so there's no right or wrong answer that's a textbook, and it really depends on a number of different things. And so I think the things that are important are, before you start a treatment, talk to your doctor. And really, I think the important questions to ask are, well, what do I think is going to be the benefit for me? And what are the logistics for me? And what is the safety for me to help you make the best decision? There are some certain factors that will influence that. And you can see with the figure on the right that I've illustrated the three different medications. So risdiplam is taken as an oral liquid medication once a day, every day. Whereas nusinersen is given as 4 initial doses over a period of 2 months, and then maintenance doses every 4 months. And it's directed directly into the fluid that bathes the spinal cord and the brain. It's called a lumbar puncture, okay? And the final one, the gene therapy, is as a single intravenous dose. That's when you find a vein, it's given into the bloodstream by putting a small tube in there. So you can see that they're given in different ways and in different frequency doses. But I think the suitability as to what's safe and what's able to be given depends. So, for example, if you've got a very significant scoliosis with a twisting of the back, a lumbar puncture may be very difficult to do, and it may not be the best option for you. Similarly, the way that gene therapy is given is that it's like posting a letter. And so you've got your genes, which is the message that you want to give. And it has a set of instructions on how to make the protein. But when you have a letter, you need an envelope. And that's so that it is safely carried to where it needs to go and it delivers the message without it being destroyed, but it also has an address book to tell you where to go. So the envelope for the gene therapy is actually a virus shell of a harmless virus. But it's very important to know that, because if you've got immunity to that virus, and that's called adeno-associated virus number 9, then it won't work and it won't be safe. And so sometimes we have to do a blood test to check your own immunity to that virus, because if you are immune, it's not the best and it's not a safe treatment for you, and that can happen. And I think it's a permanent introduction of a new gene, the functioning gene. And so it can only be a single dose, because once that has been delivered, your body will form an immunity to it. So it can't be given as a second dose with current technologies. But I think because it goes to your whole body through the bloodstream, there can also be immune reactions once your body sees that virus. So we have to know that it's safe for the whole body. So if you've got other conditions like liver problems or kidney problems or heart problems, again, it may not be the best and the safest treatment for you. So again, it comes back to the fact that it's important to talk to your doctor and to think about what is the best drug for you and the safest drug for you. And it can be dosing, and it can be a safety issue around other clinical factors that I've just explained. So it comes down to how the treatment is also delivered and what the risks are. And so if you're on other treatments or combination treatments, there may be specific risks that you also need to discuss. But it's also important, again, coming back to the point that you shouldn't be taking an SMA medication without ongoing therapy. So I think in making these decisions, it's about what the treatment is, how it's given, what the follow-up is for that treatment, but also what are the requirements for ongoing care. So for gene therapy specifically, there is ongoing monitoring and ongoing blood tests to look for the safety of that. And it's important to understand that and to be able to commit to that, both from the doctor's perspective and also the family and the patient's perspective, because if you don't, it won't be safe and it's not best care. And then I think finally, in discussing treatments and making decisions, it's about goals, and these are different for everybody. And I think it will be about what your personal experience is, and it's going to be different. And the response won't be the same as what other people have, because we're all different. And you may not be exactly the same as what the people are that had these therapies in the clinical trials. So I think it's really important to talk to your doctor about how your SMA affects you, and then what the likely response is that you are going to have from the treatment, so that you've got the right expectations going in, so that you can tell if the treatment's working and you know how you're going to monitor for that. And so some of the factors that feed into that sort of discussion is how old you are, how long you've been living with SMA, what your current function's like, and if you've had any other treatments in the past. And then I think it's also important to ask your doctor, well, how am I going to be monitored? What are the tests for safety, and what's the response evaluation going to be? And of course, a very important question is the cost and the access. And certainly, I think advocacy beyond borders, it's very challenging because these are expensive therapies. And so I think it's important to understand, how am I going to access this, and what's the path for sustainable access, because some of these do require ongoing treatment, and it would be very difficult to start and have it working and then have to stop. So it's an important discussion to have at the start. So the next slide summarises the where we are in Australia, and certainly the indications for the different. It's very hard to read. I'm sorry. These are actually still changing, so it's not set in stone. But we do have 3 approved therapies. But again, the indications to access them and reimburse them are different. So different ages, and different groups can have different ones. And a specific thing is that for gene therapy, our indication is for children less than 9 months. And I think that's important to know, because you may be too heavy for gene therapy. And I think it's a specific challenge for gene therapy, because because it's given through the bloodstream, the dose is calculated based on weight. So if you're getting a higher dose, you're also getting more virus to deliver it, and that really increases the risk of an immune reaction potentially. So that's why the age cutoff is there for gene therapy, to help you understand that. So if we just go to the next slide, please. This really shows a picture of gene therapy of onasemnogene abeparvovec, and I'm going to go through each different treatment. So you can see it's got the virus shell, AAV9, and then inside it, it's got all the genetic elements. So a promoter to turn the gene on, the actual recipe for the gene, and repeats to help it continue making what it needs ongoing. So that's what the components are to put gene therapy together. And if you just go to the next slide, this really summarises how my framework for working up a patient or a child for gene therapy. And so it's first of all confirming the diagnosis of SMA through genetic testing, and then looking to make sure that the AAV9 antibodies are not elevated that would preclude administration. And then it's examining the person to make sure that there's no other sickness elsewhere in the lungs, the liver, the heart. Doing blood tests to check up on the lungs, the liver, the heart, the blood. And I think if we actually now know that if a child has an active infection or a recent infection, it heightens the risk of an immune response. So my rule is that if there's been any infection in the last 1 month, that the risk is a lot higher and gene therapy should be delayed. And alternative treatment options should be given because of that risk. Similarly, immunisations could prime the immune system. So we like children to be fully immunised, but we don't like recent immunisations within a month as well. However, in a newborn screening scenario, if you have your Hep B vaccination at delivery, that's not a problem. I'd also note that if you do have a baby that tests with a high level of AAV9 antibodies, you're actually testing the mum's immune system at that time, because the immune system crosses the placenta. So that's a very unique situation where if you do have a high antibody level, if you wait and repeat the test after some time and think about other treatment options in the meantime, the level can come down. So there is an opportunity for retesting depending on the age of the person, and particularly newborn. And of course, before we go ahead, there needs to be a very detailed informed consent and a discussion around expectations. And so before we start gene therapy, we do start corticosteroids, which is an oral medication called prednisolone. And this is to dampen down any potential immune response that develops to the virus. And it's given for a minimum of 30 days, and it can be a lot longer. And then it's slowly reduced when it's safe to do so over a minimum of 4 weeks as well. And I think an important thing beforehand is also to educate the families and the caregivers around what to look out for, and to monitor and when to get in touch with the doctors if they are concerned. And specifically, all medications have side effects. Some are very common, some are rare. And for gene therapy, it's quite common to have fevers or vomiting afterwards for the first few days, like more than 1 in 10 children would have it. So we like to educate caregivers around how to feed children, how to maintain fluids, and what to look out for if they're getting dehydrated, and how to look after vomiting, just to make it safe through that period. And after treatment, then we do monitor the liver and the blood tests quite frequently, at least weekly, and the frequency, and it's actually quite tailored depending on how children are going and responding to it over that period. So if we just go to the next slide, this is just talking about expected outcomes for SMA type 1. And really, I think when we talk to people, I think they come with their own experience of SMA. And so it's always going to be different. And so I always like to talk about the experience of SMA without treatment, because I think this is very important in setting outcomes. So because in fact, an important outcome may be achieving disease stabilization, whereas if you have no experience of SMA, you may not think that is actually a good outcome or acceptable. So by explaining that there is in SMA type 1, there's a progressive loss of function, progressive weakness, and survival is on average 9 months, it really can frame conversations as distressing as it is. But really, I think children are growing with treatment, but they may in fact develop symptoms of SMA through treatment because they're getting bigger, but the number of nerves may well be the same and the load on them. So they may well have ongoing weakness or emergent weakness and new problems related to SMA, and that doesn't necessarily mean a treatment failure. This is why maintaining ongoing multidisciplinary care is really important to deal with the whole of SMA and the whole of the person. So looking after the muscles that help you breathe so that you can cough well, so that you can fight infections and chest infections well, so that you are feeding and swallowing well, because if you've got mouth weakness, it may take a long time to eat and you may not eat as much as what is needed to keep your body healthy, so that your muscles aren't lacking energy and that you're really well, so that when you are sick, you can get through those periods without running out of energy. So nutrition is really important, and sometimes it does require support for that. And then with weakness, it does mean as you grow that your bones may not grow in the equal rate, and there can be new problems that come, like hip dislocations or scoliosis. So it's important to be managing those. And I think we are learning, the more we treat SMA, that if we are proactive and we're anticipating this, we get better outcomes with people. But it's also supporting function and optimizing that, so that if there's ongoing weakness, that we're using equipment to really support that. So that's all really important. So if we now look at SMA type 2 and 3, again, the natural history on the next slide is really important in framing conversations. And so I think natural history is what happens over time without treatment. And you can see here that this is really important information to frame this conversation, because the y-axis, the one that's vertical, is showing a score called the Hammersmith Functional Motor Score, which is describing muscle function, or what you can do and it's a scale that we use to measure this. And across the bottom horizontally is age. Now the green, you can see that it's changing. Okay, and we do know that SMA is a progressive disease, and that over time in type 2 and type 3, there is a loss of function. And this is why it's so important to treat SMA at all ages if we can, because if we can slow that down or stop it, that is excellent. Okay, and it may not just be that improving is the goal, because if you look over a whole of life, that is really important for people. So I think For people that don't have an experience of progressive SMA, that might be very young when they're starting treatment, showing this to them and helping them understand that treatment goals and expectations is very important, but also provides the rationale for why treatment is important for all people with SMA. And again, I won't go through the right-hand slide, but it applies to all people with SMA and needs to be individualised. So if we just go to the next slide, this actually shows, again, a 12-month change in motor function by age. So it's very important to these individualised conversations with families for SMA type 2 and 3, because in fact, even without treatment, that motor function can improve in young children younger than 5. So I think this is why the stories from the clinical trial are very hard to interpret, because you have that developmental background where all children should be gaining function. So young children, even with SMA type 2 and 3, are still gaining function. It's just different to other children who don't have SMA, but it's still gained. So if you started treatment at that age, you would be expecting an improvement, okay? But then if you're older, between 5 and 15 without treatment, you are losing function. It's a different kettle of fish. So if we're starting treatment in that age and they're stable and not losing, that's actually a success, and it's an improvement and a gain. So in fact, the expectation needs to be framed against what's happening without treatment at different ages. And again, over 15, it's the same. So I think it's different because of developmental skills that happen in different ages, but it's also growth, and that as you get bigger, things get harder and you can lose function as well. And so they're called the covariates. Puberty, growth, weight gain, contraction, scoliosis can all impact the way your function changes. And they're still happening even if you start treatment at that age. So in fact, you may still have loss of skills even starting treatment at these ages. It doesn't mean the treatment's not working. It just means that you're battling against puberty and weight gain and all these other factors as well. So it's a really big balance, but I think it's important to think about these, to really think, is my treatment working or not? And it also helps understand why there's so many different stories around the world in terms of people's experiences and the benefits they get when they're starting treatments with SMA. So if we just go to the next slide, this really shows what happens when you don't treat SMA type 3. And again, it shows that over a lifetime that people do have progression and they do lose the ability to walk. So again, it's important to treat SMA across all ages and stages. So now with the next slide, I just wanted to describe what's happening and what we're seeing when we are treating SMA. So with type 1, because these children are young and they're starting treatment hopefully in the first year of life or even earlier, we are seeing improvements in motor function, but these kids do have symptoms. They are going to have ongoing weakness. You can't get back those motor nerve cells that are gone, that the scars are already there. So they are going to have ongoing weakness. So it's important to recognise that they're sitting, but they're not SMA type 2s. They can have very significant difficulties with breathing and feeding. And in fact, because they're sitting so early, and it's just such a celebration that that's happening, but they're sitting with a weak back. And in fact, that is driving a very early, can be very significant scoliosis. So we've learned that we have to approach that differently and really celebrate the fact they're gaining function, but also support them so that they're not sitting too long with a weak back and fatiguing and then getting really bad posture that's exacerbating scoliosis and the like. So we're learning about the new changes and how we really have to approach that differently. So I think it's really early scoliosis management, bracing and orthotics to help that. And on the next slide, you'll see some x-rays of some of the children that we've treated with scoliosis. And you can see that This is a child at a very young age 2, and you can see that scoliosis, it should be straight like a vertical line, but it's not. And it's actually in 3 dimensions. And so they're getting a very round back as well. So this is something that we didn't know before we started treating SMA type 1, but we're recognizing that's very important. And on the next slide, I think when we start talking about treatment, it's also important to, on the next slide, to be talking about how we're going to look after breathing, recognizing the weakness that is still there. And it can be very similar without treatment with SMA. So we need sick day plans for acute illnesses, and we need plans for when they're well as well. So cough assist, maintaining immunizations, breath stacking, helping move mucus out, freeing up mucus. And so that can be really tailored. And sometimes children do need non-invasive ventilation to help their breathing at night, to help with clearance and maintaining best breathing support for them. And on the next slide, SMA type 1, it's also when we're starting treatment and through treatment monitoring swallowing. So children can have long meal times, slow meal times, or not gain weight appropriately because of fatigue. And that's taking a huge, that can put a lot of pressure on people and be very stressful. And it's also taking away time from playing and actually fun activities as well. So sometimes we do think about supplemental feeding through tubes, and that can actually, it doesn't mean you can't eat orally if it's safe. It means that you can do both and that you can enjoy food, but you can also be healthy and maintain the best weight and not have that pressure. But I think for some people, if you are weak, your swallow means that the food can go down the wrong way and into the lungs, and that's not a good thing. It can give scarring in the lungs and it can give pneumonia. So we do like to protect the airway and monitor for that. And sometimes if we're worried about that, we do need to make plans on how to optimize that and keep children healthy. And we certainly know that we have learned, certainly I have learned through the first few children that I have treated, that if we are managing this as well as we can, we're actually keeping children out of hospital. But if we're not looking after it, that's when they're in hospital a lot and they're sick a lot, which is not what we like to see. So it's important. It improves health, improves quality of life, and stops more interventions. So on the next slide, it's about, well, what are the expectations and the approach with SMA type 2 and 3 with treatment? So there are improvements or stabilisation. There is a benefit with all 3 drugs, but it's different. So I think if you do have contractures or tight joints or scoliosis, your treatment is not going to change that. That's a fixed problem. So that's not going to change with treatment, but it can improve muscle strength. And sometimes the scales, because they are so rough and measure things when you can actually move a lot, don't actually tell us what families tell us. So some people say that it improves their neck strength so they can hold their head up for longer or turn their head to the side to talk to someone or to look at something, or they have better hand strength. They can type on keyboards or use their joystick to play for longer, or play with Lego for longer. Their voice can be louder or stronger, or they can be heard more easily. They have more endurance, which is, you know, playing for Lego longer, typing for longer, or they may have better chewing or strength or better balance. And these are things that we haven't measured, but families are telling us, which are all really, really important. And on the next slide, I think there's just some quotes about what other improvements can be. Being able to cough better, having a stronger voice, being able to move from a bed to a wheelchair, that's a huge, huge thing for independence. Being more confident or having better balance. And really, across some studies in other centres, more than 90% of people that are treated with one of the 3 SMA therapies are reporting improvement, but they can be something we can't measure, and they can be very personal and very unique, but very important. So in terms of SMA classification, when you talk to doctors, this is summarised on the next slide, because we are now seeing people with SMA being treated, the classification of type 1, type 2 and 3 gets even more confusing, because your motor function is changing. Well, hopefully it's changing. So you could be a non-sitter and then become a sitter. So do we call you an SMA type 1 or an SMA type 2? Or, but this is not the same for everybody. So I think using that classification is really historical. It was designed for a time before there were treatments. People still do use it. But what there is a shift towards is now talking about people living with SMA in terms of what their current motor function is. So how old are you? Are you a non-sitter? How old are you? Are you a sitter? Are you a walker? Now that is helpful because it helps me understand how to support people with SMA, what they need to live the best possible life, to be healthy and to be functional. So I think it's not used everywhere, and I think it's just you'll see different terminology, and that's why that's happening. So on the next slide, I'm really going to move to newborn screening, and I do acknowledge that this is not available across Asia Pacific, but hopefully by discussing it, we can understand the importance of advocating for this to become more widely available. So the first point is that SMA can be diagnosed or identified and then confirmed later through newborn screening. And that's with a very simple test that's really looking for the SMN1 gene to see if it's there or not for the important sections. And that's all it's looking at. It's not looking at other genes. And we know that this is important because time is motor neuron. So the early diagnosis you have, hopefully that allows earlier treatment, and that definitely unequivocally allows for better outcomes. So that's why newborn screening is very important. So on the next slide, I'm just going to summarize it again, and it's especially pertinent for SMA type 1. And this graph actually shows the number of motor units, or the number of nerves connected to muscles, on the y-axis according to age. And the orange is type 1, the grey is type 2, and the yellow is type 3. This was a study done in 2004, so they used that classification. And you can see that even in the first month or two with SMA type 1, there's a 90% loss of the number of motor units that you have. Even in SMA type 2, there's a very rapid and early loss. It's just less, in inverted commas. And SMA type 3, again, the loss is early in the first year. And really, it's thought that you need to lose about 60% of your nerves before you start to see anything clinically. So I think the horse has bolted. So it's really important that if we could identify it before we see symptoms, we should. And that's because the loss is so dramatic, so early, so quick and irreversible that any delay in diagnosis at that point can be very, very serious in terms of maximising the benefits from treatment. And in fact, if you look at the next slide, these are some of the cases that we've seen through our newborn screening program in where I work. And so the blue figures are actually a measure of nerve output. So if you stimulate the nerve and then you're measuring its response in the muscle, that's called a CMAP. And that's the white curve. And you can see that it's like a hill. Okay. And it's the size of the hill that tells you what your motor units are doing, how many of them are healthy. And so in my first case, the baby was identified through newborn screening at risk of SMA on day 4. And on day 18, we confirmed the diagnosis through follow-up testing. And you can see that the CMAP is 3.1, which is a nice healthy number for a baby at that age. We were getting ready for treatment and preparing for treatment. The baby looked well when I first saw them, but by the time they came in for their very first treatment, which was 14 days later, you can see it's now 0.3, 90% loss. So it's true. And it was awful. The baby had symptoms. So really, it's an emergency. If you get a phone call that you have a baby that's newborn screen positive with those 2 backup genes, which says it could be very, very serious. And in fact, this was not a one-off. We saw it in other cases. And really case 2 shows that a similar phenomenon is happening in case 3. So when advocating for newborn screening programs, which are very important, it's also about advocating for the best model of care to support newborn screening. Really, it's that whole pathway about newborn screening, contacting families, organising urgent testing, and then the urgent pathway for treatment. So it's having healthcare systems ready and drugs ready to really support these families as well. And each one of those is really, really important for newborn screening in SMA. So on the next slide, it just really shows you how you screen for SMA. So on the left is a healthy individual, and you can see the SMN1 gene is at the top and the SMN2 gene is at the bottom. So the newborn screening, it just has a small probe looking to see whether the exon 7, so the part of the gene called number 7, is present or absent. And you can see here on the bottom, the plot with all the rainbow colours is amplifying the probes. And there's 4 probes. One's a control, just check that the whole kit's working. And that's the blue one. And you can see out of every run, it's going up nice and quickly. The green probe is for SMN. And you can see that the normal curve, there's lots of green going up, and the yellow and the red are the skid probes that we can do in the same kid for immunodeficiency, which is not SMA. So here is a patient with SMA that's screening, and you can see here that the yellow, the red and the blue are all going up and amplifying, and there's lots of it being produced, whereas the green, it just goes along sideways and never goes up vertically, and that's because it's not there. So that's what a newborn screen positive SMA looks like when you do the test. And it's actually positive because SMN is absent, okay? And so when we get a test and we get a phone call like this, our job is then to call the family, get them in and examine the baby, because sometimes they already have symptoms, as you've heard, but that's not very common, fortunately. And on the next slide, it's important because the parents will go, well, what's going to happen? And so this is where SMN2 is very important, because it helps us, if the baby has no symptoms, talk to families about what could happen. And so we know with 2 copies, most people will develop severe SMA. With 3 copies, you can develop any type of SMA, so it can be very tricky. But most commonly, it's SMA type 2, but some people do get SMA type 1 and some get SMA type 3. Whereas 4 copies, it's even harder, but most people get SMA type 3 from what we can tell so far, but we still have a lot more to learn about that. And on the next slide, it's just the difficulties of, well, what is pre-symptomatic if you're seeing a baby? And the more we look at babies with SMA, the harder it gets, because it can be very subtle. It can be that they don't have reflexes, that they're very floppy, they're weak, they've got tongue fasciculations. Well, this unequivocally is SMA, they're already symptomatic. But sometimes it's just that they're a little bit hard to feed, a little bit hard to suck. Their cry might be weak, but in fact, it might be that the head control is not as good as what you want. They might have contractions in their knees because they're not kicking as strongly inside, but they're still kicking. And then I've actually found that some babies do have heart problems, so we do have to look at that as well. I've actually had babies that have, in the last year, that look beautiful, but they've got low blood sugars, because SMA can affect other parts of the body. And that's just because they're not feeding as well as what they should. And sometimes it's just that they get this mottled rash on their arms and legs, and that can be due to the way that the nerves supply the skin in SMA. But I mean, I think it's just about, it can be very hard to work out, are they symptomatic or not? And it's not necessarily black and white. There can be some grey in there for the clinicians that are there. And so on the next slide, if we get newborn screening, it's really about the care pathway. It's about the newborn screening lab, testing patients. It's a screen, not a diagnosis. And then it's about working out what the best model is for the family. Now, in Australia, it's incredibly challenging because we have some families that live closer to the equator than they do to where I practice. And then we have some families that live closer to Antarctica than the other end of Australia. Australia is just geographically enormous. So this is where it's going to be different for different families about who's going to call them, who's going to contact them, assess them. And really, but irrespective of that, we definitely need to have bloods collected quickly, going to the right labs and rapid turnaround to confirm diagnosis. But then I think an assessment to see how the baby is. And really, I think it's wonderful that there's 3 treatment options for SMA, because time and logistics are going to be different for different babies. If you're living remotely, it might be very hard to come for ongoing therapies, and an oral therapy once a day might be really good. Or if you're developing symptoms very quickly, the first treatment's going to be the best, and we could start nusinersen that day, which would be wonderful. Whereas starting gene therapy will take at least 2 weeks because we've got all of this work up to do. So it's just so wonderful that there's 3 different types of therapy, because everyone has different needs and different options, and there's a choice that can be made. But I do realise that access is difficult even for us. Not everybody with SMA gets access to therapy. So there's a lot more advocacy to do in that. So the next slide really summarises what is best practice in newborn screening. And I think it really highlights, just for people in different regions in Asia Pac, that in Australia we've got 5 neuromuscular centres, and we are definitely not covering the whole of geography of Australia equitably, but we definitely want to have equitable care for every single patient that's fit for them and really good. And I think that's going to be the challenge in every region, to work out what best practice is. But it's definitely going to be screening for SMN1 and SMN2. And that's why I'm a strong believer that knowing SMN2 number very early on helps guide best practice to help you make a decision. Because if you've got 2, you're going to run like the wind. Whereas if you've got 4, you've got time, and you don't have to alarm a family and panic and really make them upheave their whole life with a newborn baby to travel 1,000 kilometres urgently. And I think best practice depends on where they live. There needs to be a diagnosis and a treatment plan put in place. So in terms of the next slide, it's about framing treatment expectations in a newborn screening setting. And we do know that the copy number is important, because we know the disease does start early for 2 copies. And we know that even if you start and you look like you don't have any symptoms, that can change. And again, it doesn't mean the treatment's not working. It can be the challenge of growth and need, and a bigger body. So there is definitely a need for ongoing care. It doesn't mean that you're not going to get SMA and you're not going to need any other treatment. Some children do develop swallowing problems and do need some support with breathing and feeding. And some, particularly as they grow, do experience some delay in motor development. But we do know that generally, if you're starting treatment when you have no symptoms, that you are mostly going to achieve walking, although there may be some instability in walking. And I guess we need further data long-term to see what happens over a lifetime. If you've got 3 copies and you're lucky enough to be able to start treatment early on, which is not the case currently in Australia, then normal motor function and development is expected. And there hasn't been any sort of complications around breathing or swallowing or scoliosis, to my knowledge, that is expected. And just to say that we are hoping that the treatment landscape will continue to change, and it's important to be really thinking that this is an ongoing piece of work to really get the best outcomes for all patients. So in conclusions, on the final slide, I think it's really to say that there are new treatments, and I know that someone's going to ask me which one's best. They're all good. And I can't compare them, because I think all the scientific reports are not balanced. They've got different patients, so they're not directly comparable. I do think they all work and they all have benefits. And it's going to really depend on an individual, as I've said. So what we do know is that the outcomes are changing, but we are also seeing new problems or new symptoms with SMA, with breathing and following in some treated people. And so it's not just about giving medications, it's also a new approach in care, breathing, feeding, clinical status, and what people need at that point in time. So it's really customizing all aspects of treatment to optimize motor function and to be accurate and realistic in all communications. And finally, the importance of diagnosis and being consistent and working together. And so finally, before I stop, I'd just like to acknowledge a lot of people that I am so lucky to work alongside, and that's the children and families that have taught me so much. The hospital where I work and the team that also I work with, and the research team, the newborn screening service, a huge call out to Julie for all her advocacy and everything that she's done, and some of the funding bodies that have supported my work to date, and also the pharmaceutical companies that I've been lucky to collaborate with. Thank you very much.
Thank you so much. That was amazing. If anyone has any questions, now is your chance to type them in the chat box to ask some burning questions. I'll start the conversation because I'm really keen to hear your response. You know, what can we do as patient advocates, as, you know, parents on the call, what can we do to play our part in SMA advocacy in Asia Pacific? I'd love to hear your thoughts.
I think I'm probably the wrong person to answer it because I'm a little bit naive to where things are in different countries. So I think respectfully, I would need to understand that and defer to people living in those regions. However, I would say that it's about collaboration and bringing people together. So it's about clinicians with experience, scientists, but also we need all people at the table. So we need the voice of the patient at the very centre, but we also need the health system, policymakers, and the drug companies. And so it's all for a common interest. And I think if we can leave our own individual agendas aside and work together, that's really important.
Perfect. Now we've got a question. Can you please share your perceptions on combination therapy versus monotherapy?
Okay. I don't know is the answer. I think in Australia, where I practice, we are not able to prescribe on the PBS, which reimburses our drugs. It's a publicly funded system, 2 therapies. But it depends on what you mean by combination therapy. You have said versus monotherapy. So combination therapy could be changing from one drug to another, so changing from risdiplam to nusinersen or vice versa. And we do have some people living with SMA choose to do that. And I think so my perception of that is I have to understand why they want to do that and what the expectation is to make sure it's realistic, because I wouldn't like to do it and then set them up to be disappointed. So it's about, well, why are you doing it? What are you hoping to achieve? How are we going to measure that? And what would you do? When would you stop? Or when would you change back? And I have had some people go from nusinersen to risdiplam and back to nusinersen because we've had those very honest conversations, and it's usually been about route of administration and frequency. And then they change, and then they think, oh, I don't actually like the new one, I'm going to change back. And they've gone both ways. I think other combination therapies are giving 2 drugs at once. We can't do that. And so even though you think you've had gene therapy and it's a single dose, it's a permanent dose. So if you then want another treatment, it's an add-on and it's still a combination because you're still getting 2 drugs at once, and we can't do that. I know that there's reports overseas that it's helping and it's benefiting, but I'm very cautious because if you've started one drug and then you quickly add another drug, it may not be that you've got the full benefit of the first drug, and you can't compare because if it depends on the age and how long you've been on another therapy as to what you'd expect. So all these so I get people coming to me going, oh, but it's working overseas. There's lots of stories on Facebook. I can't understand those stories. I'm very open to the idea if the science proves it, because theoretically you could say, well, if one nerve cell's not actually getting the drug into the nerve, there might be a benefit from adding another. But it also may be that there's no benefit because they're targeting the same mechanism. So it's very confusing. It's hard to understand. I'm very cautious because it needs to be safe. And I'm also aware that these are very high cost therapies. And I have a responsibility about that, but I also have a responsibility to my patients to do the best for them. So I'm open to the idea, but I think it's going to be best sold through clinical trials and evidence, and those studies are happening. But it doesn't help the patient sitting in front of me on a Friday asking me that question.
Most definitely. Before we go, I'm going to invite Monica to say a few words in closing. But if everyone has a look in the chat, we've got an evaluation form that we would love you quickly to fill out. There's just a couple of questions about the webinar that you've seen tonight, and also what you thought of it, what you'd like to hear next. Would you like to see Michelle again or somebody else? We'd love to have you back, Michelle. So thank you so much from me. I really appreciate your time. And
Thanks, Julie. It's absolutely my privilege to say a huge thank you to Michelle for the generosity of your sharing, because the amount of information and the amount of personal experience that has been shared in that presentation, I think for all of the people who've attended, whether you're a clinician or whether you're a family member, I think there has been such a depth of information there that it's just such a privilege to listen to you speak, Michelle. And on behalf of Advocacy Beyond Borders, thank you so much to all of you for being part of this webinar and showing a real interest in improving the quality of life for yourselves, for your families, for your communities, and in your countries. Because, as Michelle so eloquently said, it's changing, moving the dial, shifting where we are currently at is about working together, and it's about collaborating. And when you have someone as generous as Michelle sharing all that information, you're laying a really strong platform to say, how do we go forward? And we would be delighted to help in any country to go forward. So on behalf of Advocacy Beyond Borders and everybody here, thank you, Michelle, and thank you to all of you for coming along.
And with that note, a big round of applause to Michelle. Yay, thank you. And we will bid you all farewell. Thank you for listening, and we hope you fill in the evaluation form as well. And we'll see you next time on our next webinar. So thank you very much.